Came from Hyderabad. I'm presenting a case of a 58-year-old gentleman by name Ramchandra Jadhav, resident of Maharashtra, is a driver by occupation. Came to hospital with chief complaints of pain in the right hip since 6 months and limb since 3 months. Coming to history of present illness, patient was apparently alright 6 months back when he developed pain in the right hip, which was insidious in onset, dull aching type, slowly progressive in nature. The pain is not non-radiating type, and pain is aggravated by walking, sitting cross-legged, squatting, climbing stairs, and he has partial relief with rest and pain medication. He had limp since 3 months, which was insidious in onset, slowly progressive in nature, and he is not using any assisted devices for walking. And his daily activities were restricted, such as squatting, walking, and climbing stairs. And he is not able to sit cross-legged. And he is not going to his work since 5 months.
Question? What is driver?
He is a driver by occupation. And there is no history of trauma, and there is no history of fever, loss of appetite, or loss of weight. There is no history of other joint involvement, and no history of small joint involvement. Pain was first pain since 6 months. 3 months.
I think just for the benefit of students, by the time the history presentation is complete in a long case, sometimes many of the examiners like to give you a historical diagnosis as to what you are thinking without touching the patient in which direction are you moving. So he has elaborated already, but I'll just like to highlight that, for example, pain. Now, if possible, you should try to put pain into one of the 3 common categories. He clearly mentioned that it is a mechanical pain, I agree, but just for the benefit of others, mechanical pain is at rest, he doesn't have any pain, and any movement is causing pain. The second type of pain could be of an inflammatory joint disease, because it is a hip case. So if the patient says, I get up in the morning and first 1 hour or so I am very painful and stiff, you can ask him, what time do you get up in the morning? He says, for example, 6 o'clock. He says, by the time the sun starts rising, I start feeling better. So this is the second pain pattern, which is usually seen in inflammatory conditions, like rheumatoid arthritis or seronegative spondyloarthritis. A single hip involvement, we think of seronegative arthritis more than rheumatoid. The third type of pain pattern could be, he says, I have pain almost continuously, and particularly in the night, I am not able to sleep. And he has to get up in the night to move around to relieve the pain. So this type of pain is usually seen in infection and tumors. If possible, if it is possible, then you should try to put the pattern of pain into one of these 3, which will give you a definite clue into which direction which we are moving. So from this history, it appears that it is like a degenerative disease. At rest, he has no pain, and activity is producing pain. The second important thing which I want to highlight is that suppose if these courses 2 years, 1 year or so, at the end of your history presentation, you should say whether a disease is progressively worsening with time. There can be one worsening with time. For example, if you don't treat tuberculosis, it will continue to worsen with time. But a degenerative disease may be static, or maybe a plateau will come. And the second could be a waxing and waning pattern. That is again in favor of a disease like rheumatoid. The other is improving with time. Improving with time means we are not dealing with a very serious nature of the disease. But at the end of the history presentation, you should be able to say one of these 2 things: increasing, worsening, stationary, or waxing and waning, and of course 3 types of pain patterns. This will give you a good clue as to which direction are we moving. So case history looks like a degenerative disease, and there is no no trauma, so obviously no fracture. Some other disease which is producing a degenerative disease of the joint. Thank you.
हो सकता है
Past history. Patient had no similar complaints in the past, and the patient had a skin disease since 15 years, for which he took medication on and off, one tablet per week, and he did not know what tablet to take. And there is no history of bronchial asthma, diabetes, or bleeding disorders.
Do you attach some significance to this skin disease which he is having? In relation to the hip disease, would there be any association of the skin disease with the hip disease?
Psoriasis.
So one could be a psoriatic arthropathy, a single joint involvement, and second could be.
steroid
Prolonged drug intake.
So if there is an allergic skin condition, eczematous condition, we may have been taking steroids. So this can be further elucidated by direct questioning, even if the patient doesn't come forward spontaneously. If there is a generalized skin disorder, then you can ask some leading questions sometimes, because you know that it's possible. Proceed further.
He took medication for 15 years, sir, for that skin problem.
For skin condition, was it Ayurvedic medicine, was it a quack or what?
He told allopathic medicine.
Allopathy.
Doctor has given.
Doctor?
Just once in a week.
Yeah, once a week tablet.
Once a week tablet.
So this may be the one with seronegative and all. Let's see. Okay. Once a week is with a fixed. Once a week for a disease or arthritis. And you see, if the disease, if the activity of the disease is under control now, he may not have any morning stiffness. See, morning stiffness will only be there in an inflammatory disease when the disease is active. If you have controlled it with DMARDs and other things, the morning stiffness will rather be more, and only the degenerative elements will be.
There is no history of tuberculosis. Family history, there are no similar complaints in the family, and there are no history of tuberculosis in the family. And coming to personal history, patient consumes mixed diet, appetite is normal, bladder habits are normal, and sleep is normal. And he is a chronic alcoholic since 30 years.
That's again significant.
He is non-smoker.
So have you elucidated the quantity of alcohol which he is consuming?
He consumes around 350 ml per day.
That is a significant amount. You know, have some idea about how much alcohol is related to
400 ml of
producing an
alcohol per
osteoporosis
week.
of the hip.
400 ml per week absolute alcohol.
I forgot.
Forgot anybody?
400 ml of absolute alcohol per week.
200 ml. Absolute alcohol or what?
Absolute alcohol.
400 ml beer भी हो सकता है, whiskey भी हो सकता है, wine भी हो सकता है, but ठीक है, okay.
Whiskey में 42%
Possibilities.
है.
In the end, we'll see what it is.
All except beer. Beer
General
is
physical examination.
5%.
Patient was moderately nourished, conscious, coherent, and there is no pallor, no icterus, no cyanosis, there is no generalized lymphadenopathy, there is no pedality.
In general physical examination, what specifically have you looked for apart from the general examination which you have done? What is the role of lymphadenopathy? Huh?
In infective pathology, there may be enlarged.
Are we thinking of infective pathology? What do you think? Are we in? Of course, you must palpate the lymph nodes, but from the history, the type of history which you have described, do you think we are dealing with a case of infective pathology? A patient who has been taking alcohol for the last 30 years. In that case, what particular thing you should see, particularly look for in general physical examination?
Palpate.
So if there is a hepatomegaly, fatty liver, palmar erythema, spider nevi, you know all those things, chronic alcoholism, what all it can produce? So in general physical examination, in such a case, when the history of taking alcohol is very significant, you should look for all these things in the physical. Even if they are negative, you should say that I have looked for and I didn't find it. What is spider nevi? कैसा होता देखा कभी?
It's a rash like
dilatation for this thing.
लेकिन
Arterial,
characteristic feature
arterial dilatation. Radiates outside from a central
the other varieties of
central
flesh in the
distinct
body.
point.
Okay, चलो.
Because of estrogen production.
Coming to gates.
अब इसका Dr. Dhal told you, if it is not very cold, then I think we'll appreciate for some time if you can remove the upper part of the clothing by talking to the patient, if you are willing for that, so that we are able to spine and hip are totally interlinked to each other. You cannot present a case by covering him like this. So do it.
Gait, he had a Trendelenburg gait, bipedal, unassisted, stable and trembling movement. Next,
Just for the benefit of all. You can appreciate these spinal movements. ऊपर का भी निकाल दो. ठंड ज़्यादा है तो एसी बंद कर सकते हैं और you can bear some discomfort to see the examination. He tends to take support. You see, as soon as there is a table nearby, he tends to go. He walks independently, but he tends to take support.
The stall space on the affected side seems to be decreased. Okay, so that also should come out. That should also come out in your description. It is not a purely Trendelenburg gait. It's probably an antalgic Trendelenburg gait.
he had an antalgic Trendelenburg gait. I have examined the patient in standing, sitting and supine position. In standing position, from front, both anterior superior iliac spines appears to be at same level. From the side,
Standing with
standing position, both anterior superior iliac spines appears to be at same level. From front, from side there is exaggerated lumbar lordosis. From behind there is left thoracic.
Next.
Frankly exaggerated. Okay. So I would not call it an exaggerated number. Anyway, proceed.
अब हाथ नीचे करवा दो. हाथ नीचे करवा. Ask him to stand by the side of this.
From behind, he had left-sided thoracic scoliosis.
So he has a scoliosis. Yes.
Thoracic lumbar.
Thoracic lumbar.
In the standing position, I think since he has a scoliosis, and we really don't know whether it is spinal disease is also
Forward
associated.
bending.
So I think I like to mention few more things about the type of scoliosis which he is having. Because at this stage, you see both hip and spine diseases can be combined very often. Degenerative diseases of the spine and hip can both be associated. So just say a few things about because in the lying down position we may not be able to appreciate the other things.
Forward bending, there is disappearance of this scoliotic deformity.
So that means it is it's a non-structural scoliosis, non-structural. That means it is compensating to something, not a primarily spinal only. Okay.
Now, in such a situation where you have an obvious scoliosis, there is a likelihood that you may get the wrong inference while assessing the gait. See, we are getting an impression that there is a midline shift while he's walking. But this midline shift is there even in the static position. So you have to be a little careful. And the evaluation of the Trendelenburg sign here becomes very, very important. So can you tell us about the Trendelenburg sign?
The Trendelenburg sign is positive.
Can you demonstrate that? So I think again, because this underwear
the patient.
is not a Frenchy underwear, you have to make some additional exposure. No. Yeah, the back should be towards the camera. Expose the beauty and expose. Not get a good impression.
Towards us, buttocks towards us.
30 seconds, no pain, and this thing also. Abduction के फॉर्मली नहीं होना चाहिए.
Normal.
And he is almost doing an assisted Trendelenburg test by trying to hold the with hand on the other table.
What are the prerequisites for performing the Trendelenburg test?
You should be able to stand on one leg for 15 seconds. And there are no coronal plane disturbance. There should be no coronal plane.
How do you know at this stage that there is no coronal plane deformity? At this stage, see, this is very early stage of data collection.
Yes, and
So my advice to all of you is that please do not get into this controversy. These questions can go when you are presenting this case at the exam.
At that time you know.
You have already seen this patient as a whole and then you are presenting it, isn't it? So you know the nitty-gritties of this case. But what I have observed in various examinations, if one finding goes wrong, the other finding also gets affected. So it's better at this stage you talk about only what you are seeing. Okay? So at this stage the prerequisite is just the ability to stand. It is described as 30 seconds in a one limb stance.
Examination in in supine position.
No, in the sitting position, squatting, cross-legged, all that has to be done.
He is able to squat.
Did you mention ASIS in the standing position?
Yes.
You mentioned.
I have examined sir in squatting position. He is able to
He is able to squat, he is able to sit cross-legged.
He is not able to sit cross-legged.
So in the sitting position, what happens to the scoliosis? What happens to the anterior superior iliac spine? All that is part of the examination, isn't it? So we need to know, when he sits down, does the scoliosis persist or it disappears? And what happens to the level of the ASIS? Yeah. You must have already made an observation. So tell us.
Sitting scoliosis not completely disappeared.
No, this is a diplomatic statement.
If you are doubtful, just have a look again.
This is a very diplomatic, not completely. His hands should be. He should not take support of the hands. इधर से आके देखो, इधर से देखिए आप। थोड़ा सा और टर्न कर लीजिए।
Disappear.
So it's disappeared. It's a very important find. This finding is very important, that it disappears on sitting. Go ahead. What does it mean? If on standing there is a scoliotic deformity and now it has disappeared, what does it mean? Compensation for what?
Which pathology? Suppose it continues to be like this in the sitting position, then what is the inference? And suppose it disappears, what is the inference?
If it continues, it's a structural. If it doesn't,
What is fixed pelvic obliquity?
Is the level of the ASIS also in the same plane now? It is also in the same plane. So, now you answer this question.
There can be a situation when on sitting also, the spine remains tilted. It doesn't disappear.
See, the inference, the logical inference here is, when he is standing, the anterior superior iliac spine on the affected side is lower. Okay, so there is one compensation occurring because the pelvis is tilting. And the second compensation will occur in the spine, because if he has to balance himself, if the head is going to remain central, then he has to have a scoliotic deformity. Okay, so probably the scoliosis in standing position is a fallout of the limb length discrepancy only. So since the limb length discrepancy is not coming into play in the sitting position, the spine becomes straight. That is the inference.
And if there is a fixed scoliosis, it remains on sitting also. That is a fixed pelvic obliquity. Take off the pillow under the head. Keep his hand like this.
Examination, patient is comfortable lying in supine position on attitude of the patient.
या इधर से उधर से कहीं से. You proceed.
Attitude of the patient. Head is central. Both shoulders are at same level. Arms by the side of the body. There is exaggerated lumbar.
You see, the terminology is not attitude of the patient. The terminology relating to hip is attitude of the limb. Okay? And dwelling further on what I told you in the morning, we talk about the spine, hip, knee complex. So the attitude of the limb also covers the spine. Okay? And head is central, shoulders, I don't think they fit into the hip joint examination. This may be good for a spine examination. Okay, so you need not talk about this. It seems to be redundant here.
Attitude of the limb. There is no exaggerated lumbar lordosis. Both anterior superior iliac spines appears to be at same level.
Okay.
Both hips are in neutral.
You can't say that. You can't say that the hips are in neutral. Don't make this comment. This is an inference. We are just narrating the data. We're just talking about data. We're not drawing any inference on this. You can't say there is no deformity.
Both patella appears to be at same level.
Okay.
Both patella are facing upward and outward. Left lower limb appears to be more external rotated than right lower limb. Both malleolae appears to be at same level. Ankle in neutral and foot in twisting. And there is no apparent wasting of thigh and calf. To inspection proper of left right limb.
Inspection proper.
Inspection
This
of right
was improper, what you are talking about?
inspection of right limb.
My advice to you is that after talking about the anterior superior iliac spine, the hip region is the next. If you are going from proximal to distal, in that sequence, that is the time when you should talk about the local findings of inspection of the hip, if any scars or
When I presented previously, first to present attitude of the limb and then come to inspection again.
Well, the purpose of a lecture demonstration is to change your behavior. Okay? Isn't it? So, I don't know. As I said, all of us, it's not your fault. We don't know who you are talking about that you were told by this person like this. Because the easiest way to wriggle out for a candidate is to blame it on someone. To blame it on someone because that person is not there to defend himself. Okay, but since we were talking about a sequence from proximal to distal, I think it's logical to talk about that at that stage only, rather than come back to it. This is exactly what I was talking about, that adopt a particular sequence. Do not keep on wavering. Okay?
I'll describe it.
No. You just describe.
Whatever is left, just describe.
Whatever is left, you describe. Because it wastes time.
There is no fullness of the first triangle, and there are no scars, sinuses, engorged veins are visible, pulsations anteriorly. Laterally,
Pulsations anteriorly are visible.
not visible.
No, but in which condition do you have visible pulsation? Do we have a hip condition where you have visible pulsation? I think we talk about pulsations in palpation. I think that's the right place for that. You are hinting at femoral artery pulsation or some other pulsation? Some pseudoaneurysm are you expecting? Yeah? So pulsation, let's talk about in palpation. I think let's not.
Unless they are seen on inspection, rarely. वो बात अलग है.
You see, any odd thing that you talk about is going to lead to an inquiry. Isn't it? So avoid these controversial things.
On lateral aspect,
And it's a negative observation. No pulsation. Had there been a visible
तब तो
pulsation,
बात थी.
then I would accept it. Yeah.
Yes, he has picked up one.
Visible pulsation.
on lateral aspect, on inspection, trochanter is not proximally migrated, and there are no scars.
In inspection, can you make out?
The told to see the supratrochanteric follows.
Told me. Were you told in the morning by me? So let's not say told. You have to, when you are here in a course, you are here to learn the way it is being taught here. When you go back, you can do anything. But at least let's talk in the same context while we are here.
Or if he comes as your examiner, then you can remember that.
No, if I come as an examiner, you can talk the same way as you are doing now and face the consequences. You see, because you will not have a second chance, and you will not even remember if you are following the other guy. If that other guy you are following, you are not going to learn. You have refused to learn from here. This is my assessment. You have refused to learn what.
That someone has a very strong influence on you.
I was discussing with Dr. Kakar yesterday that the best time for the candidate to pick up the case is after the demonstration, so that he follows what he has been taught. That was the main purpose. But if you continue to
So you try to stick to what has been taught to you, or if there is anything significant, then we can debate over that. But grossly, just stick to that finding, whatever is told.
Were you not convinced by what was taught? You see, because then there is no point, then we allow you to.
Yes, strong views to discuss कर सकते हैं.
I
I gave you the science behind it also.
Clear the doubt. Just wanted to clear that doubt.
Chalo, go ahead. No, it's better to stop making mistakes now if you want to, because okay.
Palpations. There is. I confirm my inspectory findings here.
You don't need to speak that.
Both anterior superior enlargements are at same level.
Lumbar lordosis comes first.
Top to bottom.
There is exaggerated lumbar lordosis.
Somebody told you that you can go to lumbar lordosis at the end?
No, sir.
Alright, start.
There is exaggerated lumbar lordosis.
Is there? Answer the call.
On inspection you said there is no exaggerated.
Now you say it is there.
Okay. And now you made a statement, I confirm my findings of inspection on palpation. And the first confirmation is
That you produced lumbar lordosis.
that lumbar lordosis is there.
Can you see some light going across? Or do you look for exaggerated lumbar lordosis in the supine position? Can you see some light? So it is not there.
There is no exaggerated lumbar lordosis. Both anterior superior iliac spines are at same level. There is no local rise of temperature. Anterior joint tenderness present. Both femoral pulses felt equally on both sides. Laterally, trochanter is normal in position. Surface is smooth. There is no broadening, thickening, or irregularity of the trochanter.
When you say trochanter is normal in position,
there is no proximal migration of the tendon.
you see, you should talk about the tip of the trochanter, because that is the indicator. The whole trochanter, we don't have any other guideline. It is the tip which tells us. So talk about best. If I were the candidate, I would prefer to say on 3-digit palpation, the tip of the trochanter is found to be comparable or identically placed in comparison to the normal.
By 3-digit palpation, the tip of the trochanter is comparable on both sides. And trochanter, the surface of the trochanter is smooth, there is no broadening or thickening, trochanter is non-tender, thus tenderness is present.
This thrust.
What does it convey?
Who told you thrust?
Yes, what does it convey? You said anterior hip joint tenderness. That indicates
Transtrocantric. Bitrocantric means transtrocantric.
Joint.
That means hip disease. कैसे perform किया जाता है?
What you are telling us is, classically it is called by some other name.
Transtrocantric.
How did you perform? Let us see the
Right.
test. Let us see.
So this is bitrochantric compression test. Compression.
I thought you just touched one trochanter. That can be there in trochanteric bursitis also. Bitrochanteric.
Call it by the correct name, unless you have been told by someone else. you don't want to name him also. This ghost is hanging on us. This ghost.
Deformities. There is a fixed 10 degree of external rotation deformity. And coming
See,
posteriorly,
not posteriorly. We are still in the supine position. In the supine position. Have you mentioned there are no swellings, no sinuses? Okay? Even in palpation, the swelling, sometimes on inspection you may not find. But on palpation you may be able to feel something. There is, and as you said, confirmation of findings of inspection. So there is no harm in making that statement to complete.
there are no palpable scars of the swelling, scars of small.
You also have talked about lymph nodes. While in that area, you're still in the local lip area. So the inguinal group of lymph nodes, at least you should be able to tell us.
There is no palpable image.
Okay.
There is 10 degree of fixed external rotation deformity. Coming to movement.
You see, when you are talking about deformities, you should talk about sagittal, coronal, then come to rotation. That's the sequence. You see, it doesn't mean that if you feel that there is no sagittal and coronal deformity, you will ignore that and go on to only rotational.
There is
You can't do that. There is, to complete your palpation, you have to tell us that there is no fixed flexion deformity, no coronal plane.
There is no sagittal plane deformity, there is no coronal plane deformity, there is fixed 10 degree of external rotation
Show
deformity.
the fixed external rotation. Show the 10 degree.
Demonstrate. When you look for a rotational deformity, do you do it in extension of the limb or flexion of the limb? Both. But you choose to start with, and the observation of the patella being in external rotation is finding in with the limb in extension or in flexion?
Inspection itself, all of us were observing that there appears to be external rotation. Now you show an extension first, at least.
Correct.
Show an extension like that only. In the supine position.
We are not asking you to do something which is not possible. It is possible, that is why we are asking you to
So
do
you
it.
stand at the foot end of the bed, try to hold the lower tibia.
Try to bring them in neutral position.
So, are you not able to bring the patella into neutral?
On the affected side. On the affected side.
No, it is still in external rotation.
Okay, go ahead.
Movements of the right.
Yeah, please.
There is active flexion of 70 degrees and and further 20 degree of passive flexion is possible, but is painful. And
Active flexion of 70 degrees. And passive?
another 20 degree, further 20 degree possible, but painful. There is no adduction or abduction.
So this limb is fixed in neutral? So this, okay.
And,
No adduction, no abduction.
there is 10 degree of fixed external rotation, sir. No further movement possible.
Now you don't want to tell us now rotation and extension. That is also a significant finding. Don't forget that.
Both in flexion and extension, there is 10 degree of fixed external rotation, sir.
Or there is more in flexion than extension. ऐसा तो नहीं? Both identical.
Both identical.
Unless the muscles are relaxed, if you try to move it in the coronal plane, you are going to probably get a wrong reading. So this patient probably has not relaxed when you were doing it. He is not relaxing now also. I am trying to sort of get him to relax. There is definitely coronal plane movement, but he is very apprehensive and not relaxing. Okay, he's not relaxing.
You have a doubt. Get the patient to the edge. It's the extended position. Are the limbs lying parallel or are they external? This leg is still external.
That means there is fixed
There
external
is
rotation.
obviously a fixed external. This is the simplest way to check. Leave him here like this. If he's actually into spasm, we'll gradually correct it to same parallel position. The two legs have to be parallel. Because a patella is a rough guide unless you mark it out. You don't mark out the position. You mark out the outline of the patella, then it becomes easy. Otherwise, it's an imaginary circular oval space that you're looking at. This is far more accurate when you're doing in the extended position. And in the same position, you can check for rotations in the flexed. So without doing anything, get into the flexed position.
And standing to avoid
Again,
external
it's,
rotation.
can you see that? It's still externally rotated.
Yes.
It's not correcting. So both in extension and in flexion,
There is
persistence of the rotation. Okay?
I want to give you one hint to the student. Most of the time in DNT examinations, a case is given twice or even thrice. Same case is repeated 2 or 3 times. And the examiner sometimes says the last candidate said there is standing infection from blue side is 25. So how to wriggle out of this situation? This because of the fact that in a painful hip, with repeated examinations, the first candidate has bugged the patient properly, did a thorough examination, then the deformities can actually increase because of the muscular spasm by repeated movements. Often you see all these deformities under GA, they all disappear. It is only a protective muscular spasm. When you do a total hip replacement, all those, when you put the patient under GA, most of the time all that flexion deformity which existed actually is not there, because it is a protective phenomenon. So by repeated examination, the deformities can actually change. So you can say, sir, probably this may be the reason. You should know how to come out of all these situations.
मेरे साथ वही हुआ रहेगा यार, मुझे पता है मेरे साथ वही हुआ रहेगा.
Definitely some movement here. Yes, I can sense there is some movement, though we cannot demonstrate it because it goes into spasm. The moment I try to move it, it goes into spasm. There is no coronal plane movement.
Measurements. Both apparent and there is no true short. Both apparent and true measurements. There is no short. And there is 1 centimeter wasting of thigh and calf compared to
Thigh and calf, 1 centimeter.
Almost completely rotation बाकी है, rotation.
Where did you measure?
18 centimeters from the medial
From knee joint line. You see, in the morning, we were experiencing, or rather the candidate was experiencing some difficulty in marking the knee joint, the joint line. So it's better to take something which is easily palpable. The anterior superior iliac spine. The anterior superior iliac spine is, you have palpated on both the sides, isn't it? You could take equidistance somewhere in the middle of the thigh.
The bulk of the thigh.
Where the bulk is there. With comparable distance, you can measure there. Okay? I'm not saying that the medial joint line is not good, but it's a little difficult to mark. To make things easy for you. Okay.
posterior.
Lamination from behind.
Have you marked the branch triangle there? Where is the mark? Normal side में दिखाओ. So this is important. These marks should stay on the patient. And even if you have said that there is no shortening, I think for completion's sake, these marks should be there. Okay? Let the branch triangle also be equal. That those links should be equal on both the sides to prove your point. Okay? चलो बोलो
Telescopy is negative, sir.
What was the cause? अच्छा चलो telescoping negative. You see, in a case like this, where there is such a severe muscle spasm that even normal movements cannot be demonstrated, I think it would, if you say that I didn't perform the telescoping in the light of
now, for example, in a fibrous ankylosis of the hip, you want to do telescoping. I think it is doesn't look nice. So we can ask the question in another manner: what are the prerequisites before performing telescope? That can also be asked. Just like Trendelenburg test prerequisites, what are the prerequisites for performing telescope?
And he should not be having so much of pain. Pain should not be there. Okay? Go ahead.
Brian's height is equal on both sides. There is no supratrochanteric swelling.
Okay, that's on the side. Examination on the side. So you tell us the findings. Let us know.
That is also not relevant, but you have drawn.
Just tell us the findings.
Tip of the trochanter is
At the middle range.
is at the reference.
Okay.
Posteriorly, both gluteal folds appears to be at the same level, sir. There is no gluteal wasting, sir. And no abnormal swellings palpable posteriorly.
How did you find out there is no gluteal wasting?
Both sides.
Is an inspection finding or what? How did you find out that there is a gluteus wasting on one side compared to the other side? क्या दिखेगा inspection?
Asymmetry of the gluteal folds.
Asymmetry.
क्या मतलब? They are best appreciated in the standing position as far as I am concerned. But okay, you can do it in the prone position also. What will you find if the gluteus maximus on one side is wasted on inspection?
Sagging, no?
आपको क्या? What did you find? Because you said there is a wasting. No wasting.
He is saying there is no wasting.
Normally in a hip disease, okay. But suppose there is wasting, what will be the finding?
You said there is 1 centimeter wasting in the calf, there is 1 centimeter wasting in the thigh.
Little unlikely that
Very unlikely that there is no wasting in the gluteal region
one of the
because
muscles controlling
any
that.
joint disease, it is a proximal muscle that wastes first. Distal muscles waste later. So possibly you couldn't make out on inspection, it was there, but it is safer in such a situation that if you want to really say कि है या नहीं है, the fact that you said there is no wasting whereas wasting distally is there is asking for trouble. So that's why all this deliberation happened, because if you had quietly said wasting in the gluteal region, it would have been end of the matter. They wouldn't have bothered. But the fact that there is a contradiction, there is hip disease, so little movement, wasting in the quadriceps, wasting in the calf, but nothing in mid. That's not possible. So it's your measurement error. So either you have, then the question comes, how did you measure, how did you assess, visual, standing, lying down? The corollaries were expected.
I think let me tell you about this because you have not answered. You see, the normal rotund appearance of the gluteal buttock is lost on that side. Normally it is round like a ball, it is flattened. The gluteal crease is slightly at a lower level. Many people think it is at a higher level because the muscle is lax. Like an old man has the sagging cheeks. Similarly, if there is a gluteus maximus is weak, the muscle starts sagging. Particularly in the standing position, you can appreciate the buttock is at a lower level on standing and not as round. This is the way you look for this.
Actually, I did not appreciate
You probably did not
Look for.
look at it. Huh? You have looked. चलो ठीक है.
should be done posterior joint tenderness.
You tell me what has your previous teacher told you? Somebody has been teaching you very extensively. He must have told you. Probably you think I have missed it in my. I should add it. So there is no need. If you have anterior, I told you the reason. To look for tenderness from behind, there are such bulky muscles. It's difficult. Even from the front, we chose an area which is corresponding to the extra-acetabular part of the head of the throat. Okay, so anterior hip joint tenderness, wide trochanteric compression. Both were positive according to you. There is no further need for doing it posterior. Okay, for that matter, lateral, you can approach from any side, but these two are sufficient to tell you that there is some active disease going on there. Alright?
Shoemaker's line, both lines are converging below and in the middle.
So this should have come in the supine position. Now, I have a few queries to you. In the standing position, this patient had anterior superior iliac spine was at a lower level. There was a scoliosis which disappeared in the sitting position. We at that time felt that there should be some shortening. But when you have measured both the limbs are equal. What was the reason for that?
Yes, yes, was at a lower level on standing?
Standing.
Did you mention this or not? He didn't mention.
You mentioned. Same level.
There is no distal neurovascular deficit. And the opposite ipsilateral knee is normal, sir. Opposite hip, my positive finding is there is a reduced internal rotation.
Reduced internal
There is 10
rotation.
degree of internal rotation, sir. In flexion and 20 degree in extension.
Differential. But there is no tenderness, no pain. Movements are, other movements are all normal.
Lymph nodes which are draining the hip joint, they were involved or not?
Not in.
Where did you check for them?
Inguinal.
The lymph nodes which are draining the hip joint are not involved? Just show me how to check for them.
Vertical. Along the
What is the role of the para-aortic group of lymph nodes?
I can't feel them.
Well, there is a hip disease. Which lymph nodes are likely to be affected?
Internal iliac and parallel.
Inguinal nodes or some other nodes? इसीलिए तो क्वेश्चन पूछा. See, the lymph will flow in the proximal direction. यहाँ का hip, inguinal nodes are not affected. They are affected because anything below the hip, not because of hip disease.
So you are duty bound to check the inguinal lymph nodes also.
That doesn't rule out that they are draining the hip.
So read about the lymphatic drainage. Okay. Then you have to find the proximal drainage. Where does it go? Alright. So what do you feel we are dealing with? What is your diagnosis? Clinical diagnosis? Arthritis. Can you elaborate on this arthritis?
It's a very broad term.
Acute arthritis, acute, subacute, chronic.
Rheumatoid osteoarthritis, seronegative,
Chronic
tubercular arthritis, all are arthritis.
arthritis of right hip, secondary to vascular necrosis.
Osteoarthritis or infective arthritis, all are arthritis.
I would like to do differential diagnosis.
What is the first amongst the differentials?
Which
Which arthritis? Rheumatoid,
Which is your first?
tubercular.
is your first diagnosis? And then what is your differential diagnosis?
Degenerative.
Osteoarthritis. Osteoarthritis है या कुछ और? Degenerative and osteo are different? जी बोलो.
मैं उधर कहाँ देखेगा?
Why are you reluctant to call it osteoarthritis and you are happy calling it degenerative arthritis? There must be something which he has told you. They are different or same? I am just asking you a simple question. Degenerative arthritis and osteoarthritis, are they two different entities?
Really, osteoarthritis, I cannot tell if it is a primary osteoarthritis.
No. Is it a primary disease? You think?
Secondary.
Secondary disease. So secondary osteoarthritis होगा क्या हुआ?
Secondary osteoarthritis.
Why are you so reluctant to call it a secondary osteoarthritis? That is the question which I am asking. You seem to be extremely reluctant to call it a secondary osteoarthritis. You are happy calling it as degenerative arthritis. Of course, I agree with you. Primary osteoarthritis is very uncommon. Agreed.
Secondary osteoarthritis of right hip.
Due to?
Osteoarthritis of right hip. Secondary to the first differential would be the vascular necrosis of right
Okay,
hip.
so that is your first diagnosis.
First time.
What is your second diagnosis? Differential diagnosis.
हो सकता है. But he doesn't have any other joint involvement, doesn't have any other.